Okay, we're back for another episode on the Root Cause Business of Medicine podcast. And today's special guest is Michelle Leary. And Davin, she was a real treat. I knew a little bit more about naturopathic medicine, but that was kind of a new thing for you today. And what were some key points you got out of today's podcast?
They're not so focused on inpatient medicine, but more of an outpatient medicine focus. And I think broadening their tool set, right, that they have to offer in terms of that natural, supplement, herbal medicine category, diet, nutrition, all that stuff. I think they go a little deeper in their training, which makes them a really good fit for an outpatient functional medicine setup. And so I'm excited for people to hear about that. And then to your point, towards the end of the podcast, we got into some really interesting questions and dynamics around, moving from a traditional kind of insurance-based billing model to one that might include memberships and other things.
Exactly. The other thing I thought was interesting is in her pre-med background, she had spent time in a cardiac rehab center and working with the NIH. And that actually, primed her for making the choice to go into naturopathic medicine, which I thought was an interesting career choice for her and one that was well suited for her. So excited to have you guys listen today. And here we go. Welcome to the Root Cause Business of Medicine podcast, where we explore what's broken in healthcare and what we can do about it. I'm Dr. Erik Lundquist, and I've been practicing functional medicine for the past 15 to 20 years. I'm excited to co-host this podcast with my brother, Dr. Davin Lundquist,
who's just beginning his journey into functional medicine. We come from different points on the path, but we do share a common goal. We want to rethink how medicine is practiced and help others do the same.
The U.S. healthcare system is in crisis, rising costs, declining outcomes, and physician burnout at an all-time high. But we found a different way, another way, a better way.
On this podcast, we dive into real stories from medical professionals who've stepped away from the traditional model, kind of like me, and have found a new purpose in integrative, functional, and alternative approaches to care.
These are authentic conversations with practitioners and friends who redefine success, not just for themselves, but for their patients and communities.
Whether you're a clinician feeling stuck, a student seeking direction, or just curious about what is possible,
you're in the right place. This is the Root Cause Business of Medicine podcast. Welcome back to another episode of the Root Cause Business of Medicine podcast. And today we have a very special guest, Michelle Leary, who is a doctor of naturopathic medicine, our first naturopath on the show. And we're super excited to have Michelle here. Interesting fact about Michelle, too, is that she did her undergraduate in kinesiology at Boston College. No, at British Columbia. University of British Columbia in Canada. She's a U.S. citizen, but went up to further north to get her degree. And both Davin and I have our bachelor's degree in kinesiology as well. So kind of fun. After that, she spent some time in a cardiac rehab and then off to naturopathic school at Bastyr in Seattle, Washington, where she became affiliated with IFM, the Institute for Functional Medicine, and really started to sink her roots deep into functional medicine and see the power and the impact and the comprehensiveness of functional medicine. And then later was a founder of Vida Health. No.
Vida.
Vida. Why not? Vera is true. Vida Health, which is life in Latin or in the Latin languages. Vida Health. And has a very successful multiple sites now. You have 3 sites?
We have 3 sites for functional medicine, 6 in total.
That's awesome. And she's going to tell us a lot more about how they got that up and growing, how they were able to branch it out and their whole model and things like that. So we're super excited to have Michelle on today. So thank you for joining us, Michelle.
Yeah, thank you for having me. Excited to be here.
So let's talk a little bit about your background first. There may be a lot of the listeners who are from a more allopathic or osteopathic background. Tell us a little bit about, kind of what led you into choosing naturopathy as the form of medicine,
Mhm.
and maybe just a little bit of what distinguishes naturopathy from allopathy. How do you,
Allopathy? Yeah, is that
allopathy?
how we?
That'd be
Allopathy,
it.
I think. Yeah.
Allopathy and
Mhm.
osteopathy. Boy, I'm just really fumbling with my word today. So,
Yeah, it's a question that I've gotten my entire career. So I hope I have this well rehearsed here. So I spent some time following completion of my undergrad, as you said, in cardiac rehab. So, for those who are familiar, this is typically when people who have had a heart attack or other event are sent to get well again in order to kind of do exercise rehab. And I had full plans on going to DO school or MD school and took the MCAT and was kind of planning in that realm. But because of the field that I was in and seeing so much of the benefit around exercise and wellness and really seeing how people were thriving and making lifestyle changes, dietary changes, I really wanted to lean into some of those passions. So I spent some time at the National Institute of Health in Bethesda, Maryland, and actually a completely different field, which was pain and palliative medicine, just as kind of a pre-med observer, and had a really interesting, I would say, pivotal conversation with the director who I was shadowing at that time. And I loved biochemistry in undergrad, and I loved the molecular biology side of science, but I was really passionate about nutrition and exercise. And I had also taught Pilates in my college career. I'd been a Pilates instructor. And so kind of sharing this with her over lunch, which was a unique opportunity for somebody to have, lunch with this really profound medical researcher. She's like, I don't know if you've considered this, but there's this school in Washington where you're from called Bastyr. And of course I was familiar with Bastyr and knew, and I actually had an ND as my primary care at the time. And, she said, I think you would probably be really well suited to check that out. And it was so interesting coming from this biomedical, professional at the time. So following that, I had spent also, again, just a handful of weeks at New York Presbyterian Hospital in New York City, where I got to do some additional shadowing. I happened to have kind of come from the allopathic medical family. So I had some insides to get some shadowing there. And I don't want to say I was dismayed, but I was really uh, disheartened in some ways to kind of see the level of satisfaction that those individuals were experiencing in mid-career. Like these are people who, and I was, shadowing urology and radiology and all these different specialties, family medicine. And people were just generally unhappy with their jobs. And not to say
yeah.
anything about New York Presbyterian at that time, but they just didn't have a high level of job satisfaction. So those kind of critical experiences at that time in my life, in my mid-20s, really made me rethink, where did I want to go? And here I had, and all the workings to be able to get into, medical school in its traditional fashion. But I just kind of had to follow my heart in that way. It was definitely a gamble. I tell people who are interested in naturopathic medicine when they come to me now that you really have to make sure that you understand that this is a field that doesn't have nearly as much structure in the postgraduate realm as allopathic or osteopathic medicine does. And so you really have to be aware of that shortcoming, because it is a shortcoming. But there are ways that you can be wildly successful, help a lot of people, but you have to understand both sides. So in a nutshell, that is some of the big influences that took me to this direction of training.
Yeah, I think that's really, really interesting. I had a very similar kind of disenchantment with medicine happening after my second year of medical school. As you mentioned, and it sounds like our undergraduate programs were fairly similar in our kinesiology programs, right? I mean, there was focus on nutrition, and it was basically about human performance. How can we optimize human performance, right? And so we had these anatomy, physiology classes, and we were talking about biomechanics and how we could optimize performance through different leveraging of muscle strengths and exercises, and then optimizing nutrition to get, blood levels and mitochondrial function, all of this at the undergraduate level, right? And then get into medical school, and it was like a whole year on drugs. Like, it's just like, and we're going to give this drug for this symptom. And it just, yeah, I was pretty disenchanted as well. And I think that's an interesting perspective. And I think this is why I think functional and integrated medicine are becoming so popular, certainly among the patient realm, but I mean, even among practitioners. And our hope in actually doing this podcast is exposing people who are in the more conventional allopathic, osteopathic realm to consider potentially the job satisfaction, the fulfillment that can be found in practicing integrative and functional medicine. It doesn't mean they have to throw away what they've learned. They just come with what they've already learned and add to it in a way that strengthens their knowledge and experience and expertise in a way that can really enhance overall patient care.
Yeah, patient care and outcomes and toolbox and all of it. So yeah, agreed.
Yeah, I think for me, being more recently moving into like more of a functional medicine space, I think the naturopathic medicine isn't something I have a ton of exposure to, other than conceptually kind of thinking about it, with my patients. Hey, let's find some alternative to medicine, to like drugs, like pharmaceutical medicine, which was the 20 plus years as a primary care doctor in a traditional setting. That was mostly what we had at in our toolbox, to your point. So, and I think this idea, of functional medicine getting to the root cause is something that we all share, right? Like your ability to get to the root cause is not diminished in any way, right? By, being a naturopath versus, an MD. So maybe just talk about that and how, I don't know, just like helping people, maybe the fact that you didn't have that bias, right? Of even being able to turn to a pharmaceutical in any way, broadens your search, or I don't know, man. I'm just kind of curious how that maybe influences you.
Yeah, maybe I should just take a step back and just kind of define a little bit of the training of naturopathic medicine, because I think it does vary pretty dramatically from school to school, unfortunately. And I also think that Canada versus the US, the training is different, even though the board exams are relatively the same. There's a couple different things there. But just to be clear, that the 4 years of naturopathic medical education, the first 2 years are grounded in basic science. So we have, a year of cadaver lab, very similar to any other professional medical discipline. We're doing all of the physiologies and medical biochemistries. And I actually think when I was in school, it was excellent. I found, the level of challenge and education to be absolutely what I was hoping for, and the basic science piece. The next 2 years are clinicals. So we rotate. The big difference is going to be that we don't do we don't have a lot of exposure to inpatient medicine. So we're not doing a lot of hospital rotations. You can do hospital rotations if there is a supervisor who's taking students, but it is not standardized by any stretch of the imagination. So I think it's really important to clarify that I think the big difference is all of our, for all intents and purposes, trainings, clinical trainings are going to be in the outpatient setting. Okay. But that I think makes us really, really good in kind of the, again, outpatient manageable conditions, which I think it's really nice to have exposure to those inpatient conditions as well. I think there's immense value in that. And I wish there was more opportunity for that. However, I think that the vast majority of those primary care oriented conditions that can be managed in a physician office, we got good exposure to all of the specialties. Now, in Washington State, where I trained, naturopathic physicians do have full prescriptive scopes, minus opioids and benzodiazepines and ADHD stimulant drugs. So we were trained in all the different pharmaceuticals and how to utilize those in our practice, in addition to the non-pharmaceutical realm. And I think one of the things that naturopathic medicine is best known for, that some people really lean into and others don't, is herbal medicine. And herbal medicine is part of the curriculum. It's a core part of the curriculum. Although I think it's probably the most intimidating for a lot of non-naturopathic physicians to learn after the fact, because number one, the research is more scarce. Number two, herbs can interact with a lot of things. So I think that there's some hesitancy in terms of just wide embracing endorsement of that, but that's maybe a different conversation. So our scope, just to be clear, does include pharmaceuticals. So when I came out of my training, I jumped right into a family medicine practice where it was largely a Medicaid population. And in fact, my medical director at the time was also the medical director for a rehab facility. And so a drug and rehab, substance abuse rehab facility. And so we were managing a lot of these folks. I was, as the resident, was taking on a lot of these folks. And while I can't prescribe Suboxone, and I didn't prescribe and couldn't prescribe methadone and some of those really high needs, it was in the kind of peak of the opioid crisis in Washington. So, from infections to STDs to all the things, you need drugs. Like, you need pharmaceutical agents in those situations. And if I hadn't had that in my toolbox, I can tell you right now that I don't think I would have been able to help the people in the way that they needed it. I don't think herbal medicine, at least in my opinion, would have cut it, or supplements would have cut it, for example. So all that to be said is that I did have this toolbox that included non-prescriptive agents that helped me assess, okay, can we start with something besides a statin? For example, if somebody has high cholesterol and they're coming in to see me. And that has been an opportunity for me to really dive into the lifestyle counseling. Okay, can we think about things that, for example, phytosterols and fiber and red yeast rice, and what else can we do before we reach for a statin that, if somebody has chronic fatigue, for example, may aggravate some of those symptoms, or if they already have a borderline A1C, it can raise that A1. So we have to be kind of thoughtful. So I hope that answers your question, Davin, and just kind of expands the base of.
No, it not only answered my question, it revealed my ignorance, unfortunately, around.
Oh, that's okay.
So that's great, and I did not even realize that. That traditional pharmaceuticals were part of that. So then, are there scenarios where I'm guessing that a naturopathic doctor isn't doing functional medicine? They're kind of more of a traditional diagnostician, and then they just have an expanded toolkit that includes herbal medicine in addition to pharmaceuticals?
Yeah, so I have several colleagues who did not go the functional medicine route, and I can talk about kind of some of the opinions within the naturopathic community that are not really in favor of quote unquote functional medicine, and
Hmm.
explaining a little bit why. But a lot of my colleagues and close friends actually went to community health. So community health centers, federally qualified community health centers, they hire a lot of NDs in our area. And I think part of that is honestly, the cost of hiring NDs is cheaper than, and they do require a residency. So somebody has to have done a residency. And they then are able to kind of help more rural communities that otherwise wouldn't have access to care. Because as you both know, there's a major shortage of physicians, even mid-levels. So a lot of NDs, I would just say an estimate, maybe 20-25%, at least of my class, ended up going that direction into community health. And unfortunately, they don't get to use their toolbox very much. As one of my friends said to me, she's like, I'm lucky if my patient has bus fare to get to their cardiologist that I refer them to. They don't have $9 for a vitamin D supplement. If I'm going to recommend a vitamin D supplement, forget about it. So, like, her and I practice very different medicine at this stage in our careers, whereas I have the privilege of working with a community that can afford the kind of fancier stuff. Right now, she doesn't, and that's really important to note. There's also a wide variety of scope in the naturopathic community from a nationwide perspective. The scope in Washington is higher than some. Certainly, prescriptive rights are not in every state. In California, for example, you do have to have an MD supervisor in order to have prescriptive rights. But in Oregon and Arizona, for example, there are no limitations on prescriptive rights. So those are two states that have a wide variety. We also do minor office procedures, such as like a punch biopsy or draining an abscess or removing a genital wart, as an example, these kind of minor office procedures. And so, again, it's sometimes something that not a lot of non ND friendly, I shouldn't say ND friendly, I should say people who are not as well versed in the scope of practice are unaware. They're like, oh, you can drain my abscess if and it's like, yeah,
Yeah.
this is what part of what we're trained in. Um, so yeah, I think it's full spectrum primary care. How I explain it is that, when it comes to outpatient primary care medicine, urgent care, a lot of, again, colleagues did choose to go into kind of these. I don't know if you guys have Zoom care down in California, but these kind of urgent care centers that are walk-in urgent cares, lots of NDs choose to kind of practice in those, but of course, referring out when appropriate.
Maybe speak a little bit to the residency component. I mean, you touched
Yeah.
on a little bit that, there's not as much of the postgraduate education uh, exposure for naturopaths coming out of, for MDs or DOs. It's almost unheard of for a physician to graduate medical school and just be a GP. I mean, that general practitioner doesn't really exist anymore, almost, and mostly because insurances will not actually contractually let you practice under their agreement if you're not board certified in some kind of specialty, right? So almost everybody in the medical world ends up with a residency and then doing a specialty board certification of some sort, or even then going on and doing a fellowship and subspecialty, right? So speak maybe a little bit to that, because you did mention that, there is an aspect of residency. It sounds like you did maybe a residency in family medicine or primary care. So maybe speak to that a little bit.
Yeah, there is a shortage of residencies in the naturopathic post-grad, postdoctoral education, and it's a big issue. I mean, I would be lying to say that I think that, especially now, I'm a residency director myself, and I see, these I want to say kids. It makes me feel old to say that. But, these new grads coming out and they just, nobody's ready to come out of a medical training program and not have some level of supervision. Nobody. I don't care if you're fresh out of
Totally
MD
agree.
school or PA school or whatever it is. You just don't know what you don't know. And so the big issue is funding. So if you were to ask 100% of this is what I think they would say, maybe 98% of students and naturopathic medical administrators, do you want residencies for all of your students? Do you want this to be required? Everyone would say yes. Everyone would say, absolutely. The reason it hasn't happened is that we don't have federal funding similar to what traditional or conventional residency programs. So these have to be funded typically by combination of clinics who want to take on a resident, or they have to be funded by a nonprofit, which is one of the big nonprofits that doing some great work. Michelle Simon, just a shout out to her. She is the CEO of the nonprofit Institute for Natural Medicine and is really doing some great things in terms of getting funding for sites to be able to have a residency, because clinics lose money in the first year of having a resident. The resident is not going to be able to be on their own. I know that firsthand from looking at our P&L, right? Residents are actually a cost center for the first year. So it's an issue. I think it's one of the reasons there is so much variability between quality of naturopathic doctors across the country. I would be lying to you to say that I would be comfortable with my friends or family going to any ND in this country. I wouldn't, right? But there are some amazing, amazing NDs who have done some incredible work, who are I'm very proud to be their colleague. But most of these individuals have done additional trainings, whether it's residencies or sought out other experiences, have trained under other physicians that are very profound in their field. So it's less conventional by all stretch, but it's not necessarily something that you can't come out of your education and be wildly successful, but it is not a standard path and it is not a guaranteed path. And so hence why I said earlier, I really caution people who are not go-getters, willing to kind of invest the time and energy and make sure you are at the top of your class, because that is how you are going to succeed. I don't remember the statistics recently, but something like after 5 years, less than half of NDs are no longer practicing. And I think part of that may be the challenge associated with, number one, coming out of school and not having enough mentorship. And number two, business is tough. And that's part of what you guys are talking to people about. But if you're trying to learn medicine and run a business and try to learn how to help people all at the same time, it's just not a good recipe. So I'm proud of the profession that I come from. I'm proud to be a naturopathic doctor. I also am very proud to be a functional medicine doctor. And I think that my trajectory has been significantly augmented because of my choices early on to seek functional medicine training while I was still in school. And if I had not had that opportunity, it was actually via Jeff Bland that I had that opportunity, I wouldn't be where I am today. And I should just put an asterisk that Jeff Bland was one of the founders of Bastyr University. He doesn't get the credit that, but he'll tell you the whole story. And him and Joseph Pizzorno are very, very, Joseph Pizzorno being one of the founders is an ND. And Jeff and him are very close and have been for many, many years. And Jeff is really one of the reasons that functional medicine and naturopathic medicine do have a lot of origins that are similar.
Well, we're going to have Jeff on our podcast here in the not too distant future.
Yeah.
We're going to have to dig down a little bit on that and see if we can get him to spill the history a little bit of Bastia. It's so interesting. And I mean, there are some common threads in terms of business preparation, both for naturopaths and for allopaths and osteopaths. I mean, none of us really come out of medical school with any kind of business sense. I do remember having some training in RVUs, relative value units, which was supposedly how we were going to determine productivity and, figure out how we could get a better salary. But it was limited. And it was like, I didn't know I didn't have head nor tails of what they were talking about at the time, right? No real sense for how to venture out into the business world, no entrepreneurship experience or mindset coming out of there. And so for most of us in the conventional track, we found ourselves, looking for a hospital program, looking for a, hospital-based clinic program, or in the case of Davin and I, because we were in the military, we ended up in a Navy, ambulatory clinic. But it was all determined for us, right? We were kind of put into this structured program that we had some influence over our productivity, but in the Navy, we could have been the worst physician or the best physician, and it would not have impacted our pay whatsoever, right? And so it's really, really kind of a shame. I'm going to go back to the residency program, and I hope I don't take too much time on this, but I find this fascinating. What do you know? Like, I'm thinking, so we have a residency program in Temecula at the Temecula Valley Hospital. It's a family medicine residency. 75% of those residents come from out of the country. Like they're doing they're not coming from U.S. medical schools. So why aren't we filling those seats with naturopaths? Like what is the barrier? Do you know what the situation is with that?
Well, I think there's a lot of politics involved, as there is in anything. I think there is a lot of similarities to how DOs were incorporated into a more conventional system. I think that was in, 1940s, something like that. You guys might know. I don't remember the history in terms of the chronological order, but there was a strong history of DOs kind of leaning in a more kind of outsider view, and there was a decision at some point that incorporated them into a more mainstream model. And I think that was largely not a DO, and I don't know the details of that decision, but I think that was largely a good decision for the osteopathic community, and they have retained kind of that root of being able to perform osteopathic manual therapy, manipulative therapy, which I think is a great tool. Now, in terms of the why, I do know that the national organization, the AANP, American Association of Naturopathic Physicians, spends a lot of money on this exact thing. And they are wildly trying to advocate for federal inclusion into Medicare. And once we were able to take Medicare, we can then my understanding is we can then have an entryway to more conventional residencies in the community health realm. And that is where the demand is very, very high. And I honestly believe, and this is again coming from someone who trains these NDs coming straight out of school, I think would be a massive service to the rural communities that need them. But there are 50 states, and every state has to license NDs in order for federal authorities, however that works, to then include them in this Medicare program. And I don't even know off the top of my head what number we're at, but I think it's in the high 20s. So we're, halfway there. So I think it's going to be a while. But if you were to query the opponents of naturopathic medical residents, my guess is a lot of them would say, well, the training is not equivocal. Well, you're right. There isn't hospital training, as I said before. And I do think that the standardization needs to be improved. But I also think we get things that the conventional system doesn't, like nutrition, for example.
For sure.
We get a massive amount of training in nutrition. We get a massive amount of training in these realms that would help treat our most fundamental crisis in this country, which is cardiovascular disease, obesity, diabetes. Like, we are so well trained in the realm of nutrition coming even straight out of school. This is one thing that a lot of NDs straight out of school do really, really well. And they are able to sit with the patient, do some really good counseling techniques, and they are able to do some motivational interviewing to be able to understand, how do we get this person to incorporate lifestyle medicine? And that is something that I think is maybe just as important, if not more important, than knowing how to manage somebody who is acutely decompensating in an inpatient situation. I think both are important to be able to be I think, well-rounded physician, but there are pieces that are missing in the big picture, I think, on both sides, and we can learn from each other. We can help each other. We can help grow this kind of new wave of healthcare, but we can't have this opposition of like, you're not as good as me, or I'm not as good as you, or, it has to be, where can we help each other? And that's what I'm hoping
I love
evolves.
that.
Yeah, I think, a couple different thoughts here. It sounds like, insurance reimbursement or, insurance coverage for NDs is maybe not pervasive across the country.
Correct.
Maybe certain communities have found ways around that through, federally funded clinics or, Medicaid type, clinics where you're getting paid differently than just typical kind of contracting with an insurance company. But sort of that aside, what I'm hearing is almost like the ND is almost like a champion for outpatient medicine done better, right? So, and because in
complete,
reality,
right?
like I see myself now as like moving towards you guys, like I want to understand herbs and supplements and how they interact. And I want to understand nutrition and I want to understand lifestyle tools and levers, right? And so like my inpatient training, the 100 and some babies I delivered at the Naval Hospital, like it's not helping me that much right now, right? Like it was cool. It gave me a broad exposure to medicine and an understanding of the life cycle. But it seems like we could make a case for in primary care, do we really need everybody to have that well-rounded teaching, or could we bifurcate and those who are interested in inpatient medicine get that, and those who understand that we could have a huge impact on this country's health by doubling down on outpatient medicine, which under this lens of functional medicine and integrative medicine is really lifestyle medicine, right? And I think that if we blended the ND with an MD who was more outpatient focused, that could be a real win.
No, I 100% agree. And I think this is part of the reason that I exactly sought out a lot of conventionally trained mentors in my early career. Not to say I don't have some great ND mentors, but I purposely sought out MD mentors because I knew that having that exposure and that call, if you will, if I'm in practice and I am worried about a patient with a elevated PSA, let's say, and I'm trying to decide whether it's, okay, referral, do I do an MRI? Do I do additional like, what do I do? I consulted a friend of mine who's a urologist who went to IFM's AFMCP, their inaugural course with me, and he then would consult me on like, what do I do for chronic kidney stones? And like, hey, what herbs should I use? And we were like, he was 15 years into practice at that point. I was 2, but we found this camaraderie and helping each other. And that's one of many examples, including me doing a year-long rotation in my 4th year with Dr. Arthi Chandra, who's a well-known functional medicine physician in the Seattle area, teaches for IFM and other organizations, and there's others. So my point being, I think, Davin, you're exactly right, is that I do feel that we're excellent in the outpatient setting. Again, those who have had the opportunity to get cross-trained in pharmaceutical therapy, because you do need to know when it's appropriate to use drugs. You need to know when it's appropriate to use herbs. You need to know when supplements can be initiated and which supplements interact with what things. And most importantly, you need to be able to triage a patient, even if it's a not acute situation. When I say triage, you need to assess, like, what is this patient's willingness to initiate some of these non-pharmacotherapies, or are they going to be non-compliant and I'm going to just lose this patient to follow-up? And so it's this dance of having both. And again, I just think there's so much we can learn from each other. And if I were to wave my magic wand and design a perfect system, which I'm sure all of us have different opinions on this, but I would have, a compilation of different trainings under the same roof, which is largely what Vida, my clinic, is trying to achieve and has done a pretty good job. I think we have some room to grow, is we can be better together. It sounds cheesy, but it really is true. And hence why I think it's so fun to talk shop when I see Erik and other colleagues at conferences, because we always learn something from each other.
Yeah, for sure.
So I think maybe if we were to distill down the early conversation we've had, is that there are options for people, in terms of career training, career paths. And I think an ND path is definitely potentially a more modern fit in terms of where things are headed, understanding, this other tool set, right, that includes non-pharmaceutical interventions. And now kind of bringing it back to the business aspect of saying, okay, well, if someone does want to pursue that path, like that seems to feel authentic to them, right?
Yeah.
Can they make a living? Can they have a business, pathway? And I think that's now maybe a good place to shift gears and understand what you guys have done and how you've been able to translate your specific background and into value creation, so that you can have a business that works.
Yeah. So I will just correct one thing that Erik said in the bio, and that is Vida Integrated Health was founded in 2013, long before I came along. So I am one of the, if you want to call it, founders of Vida Functional Medicine, which we launched in 2018. But it is a component of the existing Vida Integrated Health, which was founded by Dr. Chris Sasaki, who's a chiropractor. And his vision was right from the get-go to incorporate functional medicine into a practice that included chiropractic, physical therapy, acupuncture, massage. And he didn't exactly know at the time how to incorporate it. He just knew he wasn't the right person to do it, because his focus had been on musculoskeletal care and so on. So his practice, when he launched it in one clinic in Seattle, Washington, 2013, he hired a few naturopaths and tried to kind of do it in the realm of naturopathic medicine. And for whatever reason, I wasn't privy to exactly the details. It didn't work. There wasn't a good consistency. It wasn't the right person. The patient follow-up wasn't there. It just didn't work, although the musculoskeletal practice bloomed. So he was growing with more chiropractors, more acupuncturists, more physical therapists. But the ND realm of functional medicine wasn't working. And so I think when I came along in 2018, I think it was kind of his like, if this doesn't work, uh, I think I've done everything I can do. Right. And so here I was, at this point, 2 years out of school, finished my residency, had a brand new baby. Son, I think, was 9 weeks old when I started at Vida.
Amazing.
And bright-eyed and bushy-tailed and ready to work. And, I had the fortunate access to people like Jeff Bland and Joe Lamb and Arthi Chandra and, list goes on. Mario Robinson is the urologist I mentioned earlier, and all these people that I leaned on. And so I started to think about how we could build this into a sustainable business side as well as the practice. And so Chris, having already had at that point multiple years in running a business, he really emphasized to me, I want you to just focus on building the functional medicine side of things. And so I, after having worked at IFM, actually had been still working at IFM at that time up until 2019. I was working part-time for them. I knew what we needed to do to get functional medicine off the ground. I felt like, okay, this is what we need to do. We need to use the functional medicine timeline. We need to use the matrix. We need to establish a realm of different types of providers. I brought on Dr. Michael Corsilis, who's a physician assistant by training as well as a naturopathic physician. So he kind of has both dual training, if you will, in the realm of exposure to the conventional side through his PA. And so we grew with adding him. I think that allowed for a lot of the more ND shy patients to kind of feel more comfortable that there is someone who has the training. And he was at that point, I think, 18 years into practice. So we had someone who had a lot of experience come in. And then my practice just boomed. People were finding me on the IFM website. I had been doing a 4M training. I was already IFM CP at that point. I had done additional hormone training at the Women's Institute in Portland, Oregon. I had done a variety of different things at that point. And so we really wanted to go into the realm of how do we offer functional medicine primary care. Functional medicine primary care. And that was unique because a lot of places, and by the way, we were doing it on an insurance model, exclusively insurance model at this point. There was no cash-based services. We were not doing that. And then COVID hit, right? So practice is booming. All these kind of good things are happening. COVID hit. And we, I don't know if this is same for you guys, but we stayed open as essential workers. We obviously did a lot of telemed during that time. So we didn't have people come in who didn't need to, but we absolutely stayed open. And to the point when before there were drive-through COVID, testing sites, we were actually, for patients who had high risk, we were actually swabbing them in the parking lot when we could get those swabs from LabCorp or Quest early on. So we were kind of doing the full spectrum. How can we help our community people? And that felt really good to our patient population. People, I think, developed a level of trust with us during that time. And we expanded during COVID, meaning the functional medicine department. And what I mean by expanded is we really went into the realm of prevention of how do we reduce the risk of the conditions that we know are associated with worse COVID outcomes. How do we early on look at what is long COVID? What does that even mean? What's the pathophysiology? What can we learn from SARS virus in terms of if there is any association? What botanicals could potentially be utilized in early COVID infection, even though the research is clearly just not, it wasn't there and is barely there now. We were kind of just doing what we could within a safe realm. And I always like to emphasize. So from a business perspective, I think the shift that happened during COVID was largely because people became aware of their underlying conditions and how that could influence something in an acute care situation like COVID, right?
Mhm.
So the growth that happened following that, we hired additional physicians, we started a residency program, we initiated a way of people being able to get in same day, and we, reserved same day appointments as many primary care clinics do. We really made sure that people again felt well taken care of, and the demand became so significant for our docs that we were burning out, which I know you guys are familiar with, right? And many people who potentially are listening to this may be familiar with. So we needed to do something different. And the option to do a membership model presented itself mainly because my waitlist at the time was a year for a new patient. And I think I was seeing my follow-ups every 6 weeks. That didn't feel super good to me. They could see my resident sooner, but it was too long to see me. So we launched our membership model in 2023, and we did this a little cautiously because it was difficult. And I know many people who go through this transition can relate. It was difficult for us to say, hey, we're going to charge you to see me regardless. You're going to pay a monthly fee in whether you see me or not, you're going to pay this fee. And then the way that the insurance world works in Washington State, we have a model where you're paying for non-insurance covered services. So it includes adjunctive things like a DEXA scan and preferred scheduling and several other components that are separate than billing for an office visit. So the insurance piece was still on board, but the membership was for non-insurance covered services. And I had to say goodbye to a lot of my patients who said, hey, this model doesn't work for me financially. And that was hard. But in the long run, which I can pause here and ask if you guys have any follow-up questions on that, it was the right decision for the clinic because now we've been able to grow and expand our reach. And we still have a residency program, which allows patients who do not want to sign up for a membership to still have access to care that residents directly overseen by myself and other certified functional medicine physicians. And we feel really good about still being able to support our community without having to not be able to pay our doctors what they're worth, having to see so many appointments that everyone was burning out, medical assistants burning out, doctors burning out, nurses burning out. So I'll pause there. I know that was a long ramble.
Yeah. I mean, a quick thought is COVID, right? So do you think, I mean, obviously you guys were providing a lot of value because, again, you were kind of like going upstream into their conditions a little bit, right? And saying, hey, let's get ahead of this so you don't end up as one of those people, that you're hearing about on the news, right? In the ICU or whatever. So there's that aspect, which was a trust factor for you guys. Also, maybe, what do you think about just, COVID as revealing or having people sort of question the traditional model, right?
Mm.
Because I think all the mixed messages is, who has the truth, who's telling us the truth. I think from my perspective, people began to question a little bit the traditional model where there was this kind of inherent trust. Now maybe people are questioning, is there a better way? I'm just curious your thoughts on that.
Yeah, I think that's true. I think that the patients who were questioning, is there a better way? I think there was a lot of fear, obviously, during that time. And when people are worried about their families, about their own mortality, about something out of their control, they start to look for things that they can control. And I think functional medicine and doctors who were able to offer support. I think it's a fine line between promising something that you really don't know, meaning like none of us knew what was going to work and what wasn't. We just kind of had some theoretical, okay, we think this is absolutely safe. Is it going to harm you? No. Okay, well, let's do that because we think that there's plausible outcomes that could help. I think that's where people were looking for us. Okay, yeah, there's a lot of unknowns, and what do I do in terms of, how do I protect myself? But this person has at least something to go on. This doctor has at least something to go on that's plausible versus the conventional community is just saying,
There's
yeah,
nothing.
like, well, come to
Good
us if
luck. Good
you're
luck
really,
if
really
you're really
sick.
sick. Yeah.
Come to us when you're almost dead, and we'll try
Right,
and revive you in the
right,
hospital, right? I mean, and so it made it really challenging, I think, for individuals, to your point, where they felt like they had zero control or influence over that. It was like you were just waiting for, the spirit of death to come by and grab a hold of you, and you were hoping to shake free before the Grim Reaper finally, clocked in. So I think, to your point, that you guys seeing that, feeling that within your community and providing that service became a powerful impact, not only on the community, but also on your practice, right? And things really started. We noticed something similar. The demand for integrative and functional medicine during COVID and after COVID has skyrocketed. And I think that some of this is just to the dissatisfaction of conventional treatments and not being able to get the kind of care and just even being heard. I mean, it's one thing to say, okay, there are no scientifically proven treatments right now that are going to help you. And it's another thing to say, let's do something versus, so just go home and do nothing, right? I mean, it just was, and because of your background in lifestyle medicine and natural medicine, there was a lot of things that were safe, that made sense physiologically, that
correct.
would allow you to optimize an individual's performance, going back to kinesiology. And this was the performance of protection, right? Performance of the immune system being able to fight off these infections, or at least resolve or modulate the cytokine storm at that time. So I think that's super interesting. Speak to a little bit then to how the membership program changed the burnout, the culture of your practice, from a business standpoint. I mean, I've talked to colleagues and friends who are struggling with this, trying to transition into a membership program, and they don't want to give up their patients, right? They're like not satisfied with how their practice is much, but they also are providing a service that isn't able to be given through a cash-based practice. And so it becomes this tug of war between
Mhm.
their compassionate heart and their ability to keep a business functioning, and their job satisfaction.
Yeah, I think the membership model was a must for us because we weren't going to be able to keep our doctors. And from a financial perspective, you can see 20 plus patients in a day. And the reimbursement, in order to have a medical assistant for all the providers, in order to have, um, a at least break even P&L at that point with all the supplies that are required for primary care and things expire, and just managing the business side, we had to do something because insurance was not adequate. Insurance reimbursement was not adequate. And largely functional medicine is consultative, right? It's not typically a very procedure heavy. There's some notable things that we do like trigger point injections and, as I mentioned earlier, some office procedures, but largely we're not a procedure heavy practice. And so the reimbursement was just not adequate for basic E&M codes, 213s, 214s, even 215s. And the challenge was, how do we do this? And number one, make it so the doctors don't burn out. And so when we transitioned, we made a decision to have a tiered model. So we had a resident, actually two at that time. We had two residents, and we had other associate physicians, Dr. Corsilis being one of them, and then myself, who's the director of the program and just has more administrative responsibilities. So my panel size was going to be lower. So we had 3 tiers of cost. And patients were given the option of one of these 3 tiers, essentially. And if they chose not to engage in one of these tiers, they could see a first-year resident under the supervision of one of the attendings. And that resident would only have limited appointments. So it really encouraged people to go with the physician they had already been seeing for, at that point, usually a few years, several years. And I think that people understood it. I think patients understood it. They got it, because this is not a secret that there is a lot of change in the medical reimbursement model over the years, even in the last 10 years. And they felt like it was valuable to them. Patients felt it was valuable to them to be able to get a longer appointment with their doctor. They felt like it was valuable to get some of the preventative services that we were offering, such as a VO2 max and a DEXA scan. And there was, discounts on things, again, those non-insurance covered services. So the transition was not as difficult as we thought it was going to be for patients. Of course, there was some pushback and some disappointed individuals, but the conversations were essentially, we will work with you until you find another provider. We're not going to do any abandonment here. If you aren't able to get your blood pressure medication filled, don't hesitate to reach back out to us. We will help you. We had a list of non-concierge or non-membership providers we were referring out to. We made sure that this was a hand-holdy process for our patients in the transition. And I think people felt really good about that we weren't just like, okay, figure it out, you're on your own. Our resident, interestingly, our second-year resident at the time, who had a membership fee of, I think it was $79, she filled up first. So her panel, I think, filled up in 30 days. And so I think that was the sweet spot of the pricing, but also she wasn't brand new. She filled up right away, which was a surprise to us. We did not think that was going to be the case. I think it was then me, because again, my panel that I was taking, then it was Dr. Corsilis, who had a much larger panel that he was taking because of his clinical hours. And then I think it was the non-concierge individual that then was getting a trickle-down effect.
And Michelle, do you mind sharing what prices you had for your different tiers?
Yeah, so this is when we started in 2023. They have since gone up, but in 2023, it was $79 for our second-year resident. At the time, we did $189 for our associate physicians, and I was $249 per month at this time. And we did do an annual membership discount. So they got essentially 1 month free if they decided to pay in full. And, we weren't going to force anybody to stay if they really didn't like, we were going to refund them prorated, but they did get a discount if they paid in full.
Yeah, and one of the things that I've heard about the membership program versus, paying an annual versus membership is that you need to get an escrow account to put that money in so that you have that available. So if somebody cancels a membership, you can prorate it back. Is that what you guys did?
I honestly am not that in depth on the accounting side. We have kind of a big team. I do know that there were conversations in that realm, but I wouldn't be able to tell you the exact details. But I do know that we've always been able to accommodate if somebody's
Yeah.
had that request. So, yeah. And we were lucky, just to add to this, I call it kind of big Vida and little Vida, meaning the Vida that was more the musculoskeletal medicine side that was, established well before the functional medicine side. Functional medicine was kind of like a startup within big Vida. And so we had funding, I would call it,
Yeah.
that cushioned us. And that was a huge benefit, which I recognize a lot of medical only practices don't have that luxury per se, but it surprised us how quickly the program grew from the 2023 model, and people understood it. They got it.
Yeah. How long from the time you made the decision, okay, we're going to go to membership, to rollout? Like, okay, now this is day number
Mhm.
1 of the membership.
It was around 6 months. And we had sent out multiple letters, emails, communications. If we didn't hear back from somebody, we had our team call them. We just made sure that everybody was aware of this change. Again, because there's laws against patient abandonment, number one. And number two, it's just the right thing to do. We had a whole bunch of people in our system that we were responsible for.
Yeah.
We were their primary. So we wanted people to be really clear.
So were you able to
This-
keep track then? You kept track of people who at least responded yay or nay, right? You wanted
Correct.
an RSVP
Yes.
from every single patient so that you knew
Yes.
that you were taking care of them. And
Yes.
if they said, no, we're opting out, we're not going to participate in your membership program, then you walk them through then what that transition would look like, in terms of, okay, we'll see you for a little bit until we're filling up and we can get you referred to a non-member,
Correct.
referral out. We're not going to leave you hanging high and dry, but we do want you to participate in the membership if you're going to be our patient.
That's exactly it. And we made sure that if we didn't hear back from them, we made multiple attempts and we documented those attempts in a formal way, because we do want people, and people move, they change their phone numbers. I mean, it wasn't always easy, but vast majority. And if somebody did call a month after we launched, I remember multiple times people are like, oh, I didn't know. Well, we took care of them until they could find someone else.
Well, I just think that this topic will be really interesting to our listeners, because I think there's a lot of people out there probably, wondering how to make this move if they're already in practice. And you guys navigated it successfully, and it seemed like it's helped your business, one, financially, but also like from a quality of life for your practitioners. You would say that you kind of, like, the goal of this transition were met? Is that your impression, or
Yeah,
is it not all good?
It's a really good question. I think that we still run into challenges with physician burnout. I'd be lying to you to tell you that doesn't still happen, because people are still with patients 8 hours a day, many days. The difference is they're seeing far less patients. So, you might see 10 people in an 8-hour day as opposed to 25, right? And that makes a big difference in terms of uh, what you're needing to do. But the complexity of those visits is typically deeper. You're often going into more complex laboratory testing, and you're spending that 45 minutes. Our follow-ups are 45 minutes, our new patients are an hour. You're spending that time reviewing really in-depth data that requires a lot of mental energy. And so I wouldn't say that we have accomplished the goal of everyone just coming to work singing and skipping, and I don't think that is true. I think our providers are largely very happy with the structure. I think they feel supported. I can't speak for them specifically, but I What I'm told is they feel really supported. We make sure that they have an AI scribe. They all have a paired virtual nurse, and they have an in-house MA or LPN nurse. So there's a lot of support staff. And part of that model, that paired nurse, is the portal, our physician portal or our EMR portal. Patients are typically able to get a response about a question within hours, if not within 24 hours of sending that message. And the responsiveness, I think, is one of the biggest retention aspects of our program, in addition to my bias around, I think our doctors are amazing. I truly believe that. But I do think that having quick responsiveness is so different than what conventional medicine offers. And the customer service forward approach, that people are wowed by that. They have a sore throat. They call the front desk. The front desk immediately transfers them to the paired nurse of their provider. That paired nurse, RN, she or he will triage the patient. So, okay, you have a sore throat. Do you have any trouble breathing? Have you done a COVID test at home? Do you have a fever? Blah, 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 blah. They just kind of get, obviously, a triage. If they assess that the patient does not need to go immediately to the emergency room, they're typically able to schedule them same day, if not with their provider, but with a provider same day. It's most of the time their provider. And then they are able to be seen and et cetera, and taken care of. And that, I think, has been, if I can speak to the secret sauce, it has been the number one thing that when people talk to me about what keeps them at Vida, it is because they feel so taken care of and responded to. And we have so many different avenues that we try to achieve that on a daily basis.
That's great. So it almost sounds like there's two aspects to this, right? Like the concierge nature, right? If that's the word that we need to use, right? Is that convenience, ultra convenience, access is top notch, and responsiveness. I think that's really interesting, because I think that's more on the concierge side. Whether you're functional medicine or traditional primary care, people like that. People like that convenience and access. So, but the fact that you also have that deeper functional medicine breadth to the practice, right? So, you may have people that just are pretty healthy and they just love that convenience. And then you have others that really need that deep, complex understanding. So it's almost like a great combination that's complementary.
Well, I probably have another 3 hours of questions for you, but we only have about one more minute of recording time today. So we're definitely going to have a part two, Michelle, if you're up for that.
Yeah.
But we'll give you the last question here that you can kind of shout out, and it'll be interesting to get your perspective on this. But what do you see the future of functional medicine being over the course of, say, maybe the next 5 to 10 years?
Yeah, I think that we really have to look at what Lee Hood and Jeff Bland both developed kind of simultaneously, separately, but simultaneously. And that is functional medicine meets precision, or P4 medicine. And that, to me, is, and I'm a little bit of a groupie of Peter Attia, if I can just say that. Peter, if you're listening to Erik and Davin's podcast, I'm a big fan. Is what he calls medicine 3.0, right? And how we can look at these 4 horsemen, which are described as cardiovascular disease, diabetes or metabolic disease, Alzheimer's disease or other types of dementia, neurodegeneration, and then cancer. If we can look at these 4 areas from a preventative lens, and we can develop or use tools that we already know are evidence-based, such as VO2 max assessment, using grip strength, basic things that DEXA scan, basic things that we can get data on to predict, is this person on a trajectory for health, right? And visceral adiposity being one of the big markers we look at on a DEXA scan. I'm not just using it for bone density. We're looking at it from a full body composition perspective. Those types of things really matter. And so medicine, when you call it 3.0 or you call it P4 medicine or you call it functional medicine, is looking at how do we put all of these assessment tools in addition to laboratory data, standard laboratory data, but also potentially genomic data, use AI to help us understand it so you're not spending 3 to 4 hours prepping for every patient chart, because that's really what it would take to assimilate all of this. And then coming up with a plan, right? What is the plan for the patient in time 6 weeks? What is the plan at 3 months? What does the plan look like at 6 months? So people see, okay, this is what we need to do. And lifestyle, just like functional medicine has the bottom of the matrix as movement, nutrition, meaningful relationships, sleep. What am I missing here, guys?
Stress.
I feel like
Stress.
Thank you. The bottom of the matrix is where it has to start, but the tools that we have in functional medicine, naturopathic medicine, the combination of allopathic plus functional medicine, however you want to call it, that is what is going to allow us to get there. So that's my vision.
That's awesome. And you've inspired me. I'm going to do what I can to get a naturopath on staff at the residency in Temecula, because I think that I just can't imagine what my education would have been like doing rounds in the hospital if we had a naturopath instead of a registered dietitian. Now, nothing against registered dietitians, but they're trained very specifically in a myopic view of nutrition, and it's not their fault. It's just the way the training is. But having somebody who understands how to use food as medicine and understand the interactions, wow, that I can't underestimate how impactful that would be for hospital stays, for readmissions. I just think it would be super, super valuable. So thank you so much, Michelle. This was so much fun. And we're definitely going to have you back on for membership program part 2, where we can get into maybe a little more of the details of, what systems you used, what companies maybe you have helped you out from a billing standpoint, how you structured that. And I think even from a mentorship residency training, right? Because one of the challenges in any functional medicine practice is finding a provider. You can't find a provider who's already trained that's willing to uproot and come join your practice unless you have a lot of deep pockets and you can lure them away with money. Right. You have to train new ones, right? And so I think a part of what I would love to dive in a little deeper is just your system of residency or mentorship, because there's a lot of conventional medicine doctors and nurse practitioners, physician assistants who want to get into this field. They're doing some of the training, but still practicing functional medicine in a clinical setting, in an insurance-based model, is really heavy lifting. And really, so to your point of still, despite the membership, there's some burnout because it is hard work, right? Yeah. So having some mentorship, having somebody you can go to help offset that would be really powerful.
Pitch out there for anyone who is interested in exploring having a naturopathic residency at their clinic and understanding all the details of that. Michelle Simon, who's an ND, PhD, Institute for Natural Medicine. She runs a nonprofit. She's a great resource.
Davin, any final words?
Well, I'm a Peter Attia fan as well, so maybe if we say his name enough, it'll come up in the search, and his people will reach out to our people. Who knows?
Yeah.
Yeah, our people being 2, right? You and me, that's our people, right? All right, well, thanks, Michelle.
I appreciate it.